endometrial stromal sarcoma to the inferior vena cava and the right atrium. So from the title, you can see that we have a gynecological malignancy. So let's start with a brief background about that malignancy. So endometrial stromal sarcoma, it is a rare uterine malignancy, accounting only for 0.2% of all uterine malignancies. It is classified into low grade and high grade. The low grade is carrying a better prognosis than the high grade. However, it has a very high recurrence rate. Almost 50% of cases will have a recurrence. So this is not a small number. And typically, the recurrence happen after several years. So there is a long period of latency. Usually, it doesn't metastasize. However, when it metastasizes, usually it goes to the pelvis, abdomen, and the lungs. And very rarely, we see it metastasize to the heart or large blood vessels. So after this brief background, let's talk about the case presentation for our patient. So we have a 49-year-old Saudi female who is known to have a low-grade endometrial stromal sarcoma 6 years ago, which was treated with total hysterectomy with bilateral salpingio or oophorectomy, which is the removal of the uterus together with the fallopian tubes and the ovaries, so radical resection. And also she received the radiotherapy. And actually she was cured from the low-grade endometrial stromal sarcoma that time. So our patient has had two presentations. The second presentation was to our hospital, but the first presentation was to another hospital. So her first presentation was a history of 4 months of shortness of breath with easy fatigability. And with further evaluation and clinical examination in that hospital, she was suspected to have a pulmonary embolism. And that's why CT scan with contrast was ordered. And indeed, it showed that there is a right pulmonary artery embolism. But beside that pulmonary artery embolism, incidentally, they found that there is a right psoas muscle mass. So in the right psoas muscle, there was a mass and associated with IVC thrombosis, or let's say IVC filling defect, because we don't know still if it is thrombosis or not. And because the mass needs evaluation and
hello, dear Hasan, sorry to interrupt.
Yes.
We noticed that your slides are not moving actually. So can you please enable slideshow?
Sorry. Okay, I will. Is it moving now?
Yes, is it moving now? It's moving now.
But I can't put it in the full screen, I think. So just I will try something.
On the bottom of your screen, you can see slideshow. On the bottom of your screen, yes, that one. Yes.
So now you can see it, right?
Yes,
and
yes,
moving.
yes.
Yes, I'm sorry for that.
It's okay. Thank you, doctor. Thank you.
Thank you. So I was talking here that the mass in the right psoas muscle needs to be evaluated. So a biopsy was taken from that mass, and it showed that it is a recurrence from the low-grade endometrial stromal sarcoma, which was diagnosed 6 years ago. And it is histologically low-grade endometrial stromal sarcoma. And that's why the patient was thought that she has IVC thrombosis. So anticoagulants were prescribed, which is enoxaparin. And also for the right psoas muscle mass, as it is low-grade endometrial stromal sarcoma, hormone replacement therapy was prescribed, which is tamoxifen. And then she was discharged. The second presentation to our hospital was 1 month later, when she developed abdominal pain, epigastric abdominal pain, and vomiting. And associated with that, she had hematochezia, rectal bleeding, dark urine, and weight loss. She lost weight 5 kgs in 1 week. And with physical examination, there was abdominal distension and tenderness, which was suggestive of intestinal obstruction. And at that time, we were afraid that the mass, the right psoas muscle, might be the cause, that it extended to the bowels, the adjacent bowels, and led to the obstruction. That's why a whole body CT scan was ordered. And the patient, in such a patient who is relatively stable and with relatively mild symptoms, she didn't complain of severe symptoms. We can't expect to have such a terrible pictures here, as you can see in this CT scan. First, in the sagittal view, we can see here, I hope you can see my indicator, the mouse. There is the mass in the right psoas muscle, and also there is a very large filling defect in the IVC. And the IVC is hugely expanded. The IVC is not like this usually, it is smaller. Here it is expanded, and with closer views, we can see that it is also extending to the right atrium, here in the sagittal view and the coronal view. It is obvious that there is a filling defect in the right atrium. So together with that, we saw also the right pulmonary embolism, which was diagnosed 1 month ago. So in a patient with a mass extending to the right atrium, echocardiogram is definitely needed, and we did echocardiogram. And here we got shocked actually, because this echo is very terrifying pictures. As you can see here, I wish it is not lagging a lot, but as you can see here, there is a right atrial mass, which is very large. It's almost occupying 90% of the right atrium. And also, it is highly mobile. With contractions, it is moving to the right ventricle. So let's have frozen pictures, as you can see here. While it is in the right atrium, it is occupying almost 90% of the right atrium. And it is very mobile, that it is moving to the right ventricle, and also it is occupying a lot of the space of the right ventricle. So having a right atrial mass like this, very huge and very mobile, is very dangerous, because at any time, even at the time we are doing the echocardiogram, it could embolize. And such a huge mass, when it embolizes, it will definitely occlude the main pulmonary artery, and the patient will immediately and suddenly die, and the resuscitation won't be that helpful. And also, at this time, the patient needs emergent treatment, because as I mentioned, it could embolize at any time. However, we would think about also the IVC thrombosis. Why the patient didn't improve with the anticoagulants. Anticoagulants should reduce the mass, or at least prevent expansion, further expansion. However, this patient, the mass enlarged considerably, even though she is on enoxaparin and tamoxifen. So we think, is it thrombosis, or is it actually thrombosis, or there is something else? And as we don't want to put the patient in invasive procedures, we will do a PET scan, which will help us to differentiate. So PET scan was ordered, and here the case is getting even complicated. As you can see here, the primary mass in the right psoas muscle is showing increased FDG uptake, which is homogeneous, meaning that it is purely purely tumor. And also we can see that there is extension to the bowel lobes adjacent to the mass, which is mainly the ileum. And that explains why she presented with the partial bowel obstruction symptoms. And also when we go up, we can see that there is increased also FDG uptake in the IVC, but here it's not homogeneous, meaning that some part is showing and also even in the right Regarding the medical treatment, as you saw, it didn't improve the patient. In opposite, the patient get even worse with from first, most of us would say that this patient is for surgery. Cavectomy and right atriotomy might be the option, which is the resection of everything, the IVC and the right atrial mass. And that actually helped multiple cases with a similar presentation to our patient with tumoral thrombosis. However, our case is different. Why? Because the primary tumor in our case, in the right psoas muscle, is unresectable according to the opinion of multiple oncology surgeons. And that's because the tumor is locally very invasive and it is invading multiple surrounding organs. That's why it is unresectable. So surgical option won't be the good option because resecting the IVC, tumoral thrombosis and the right atrial mass without removing the primary tumor is not reasonable, as the recurrence rate will be very high because the tumor is rapidly growing, and also because the surgery is very risky. There is a very high risk of embolic showering either during the surgery or soon after that, which will lead to the death of the patient. So this will put extra risk on the patient. And angiovac system was discussed as a suggested method of management for this patient, and it actually will help us in what we were afraid of, which is embolic showering, because angiovac system has two cannulas. It works by catheterization of one vein and the removal of the thrombosis, and at the same time it will prevent any embolic showering. And in a case series, it actually helped in the removal of large thrombosis in the IVC and the right atrium. And however, those cases were all pure thrombosis, not tumoral thrombosis as in our case. On the other hand, in a case similar to our case, angiovac system was used actually. However, didn't help the patient because this kind of tumoral thrombosis has a very adherent nature to the vessel. So the angiovac system won't be able to remove it from the IVC. And that was unsuccessful, unfortunately. So angiovac system is also not the good option. You had only one last resort, which is chemotherapy, and which was combination therapy, gemcitabine and docetaxel. And this was the management plan for our patient. So the management plan was chemotherapy, gemcitabine and docetaxel, combination therapy. We hope that it might help the patient and the tumor to shrink. And then, unlikely of course, but then we might do surgical resection if the tumor shrank and reduced in size. However, the patient might be taken to the OR much earlier than this, and this when the patient develop a complete bowel obstruction due to the invasion of the bowel loops, or when the risk of embolic showering increases. And that will be evident by echocardiogram, which is done regularly for the patient, because the risk of embolic showering will increase if the right atrial mass increased in size and the mobility increased. However, if the patient was had underwent the surgery, it will only be life-saving surgery with immediate outcomes. However, long-term outcomes won't be affected. It's not done for long-term outcomes. And the patient indeed received 5 cycles of chemotherapy. However, unfortunately, what we were afraid of happened, and the patient developed pulmonary embolism due to embolic showering from the right atrial mass. And unfortunately, resuscitation were not helpful, and we lost the patient actually. And what I want to say in conclusion in my case, that these patients with the history of low-grade endometrial stromal sarcoma should have very close and regular follow-ups, because as you saw, these cases need prompt diagnosis and management. Otherwise, the tumor will rapidly increase in size and complicate the case, and put us in such a situation that no treatment is available, only chemotherapy, which was palliative, and it also didn't help. And I want lastly highlight the importance of multidisciplinary approach, because this case in our hospital, we had cardiologists, cardiac surgeons, vascular surgeons, oncology surgeons and oncologists. All of them were discussing this case, and all of them made the last decision. But unfortunately, we lost the patient. And here are the references that I discussed in the management. You can read it. And thank you for your good listening. And I'm very happy to answer any questions you have. Thank you.